Thank you, Paula, for introducing me. I'm going to talk today about advanced clinical skills and why bother? And it's my belief that we actually should bother. Let me preface this by saying that I'm actually from the country. I'm from Shepparton, and being in the country, there's actually greater pathology up there. We have bigger holes, we have worse periodontal disease, so we're more exposed to it. But the other thing too is we are professionally isolated, which means access to specialists is far more difficult. And sometimes we are forced in a position where we have to provide these services. Let me say with these advanced clinical skills and general practitioners doing it, DHSV have actually endorsed it by expanding the access to those item numbers associated with advanced clinical skills. So public dental clinics, if you have the skills to do these sorts of things, you can get reimbursed through the DWA titanium portal, and it's good because previously I used to full band up. It used to be a URA, which didn't seem to be worthwhile the reimbursement for it. What we do now, these are the sort of things which we do. Might not sound, some of the things might not sound fairly advanced, but I thought I'd put them in. The third molar surgery, the biopsies, fixed ortho, molar endo, obturators, management of some of the oral medicine conditions, and some simple fractured mandibles. Why do we do it? Well, one of the reasons why we do it is access to specialists is quite difficult. From where we are, but also getting access to the specialist centre like the dental hospital can be quite difficult. For example, the orthodontic department, and it's no reflection on the orthodontic department, but they have the index of orthodontic treatment needs, and to get access for treatment, you have to have an index of 4 or 5, which equates to about a 9mm overjet, which is for some people, for most people, that's like a facial deformity. And really doing that stuff locally, it's a greater service to the patients, and because some patients cannot or will not travel, and the patients do appreciate it. It's actually more interesting as a clinician and satisfying to do that, and also the staff you work with find it more interesting and satisfying as well. It's helping others. And the staff get a tremendous amount of pride in where they work and what they do to help patients. It's also there's great opportunities to learn, and for others to learn. We have a lot of new graduate dentists and a lot of students as well, and we've found it's a great employment carrot. In the last couple of years, we've had over 80 applicants for just a couple of new graduate positions, which gives us the great opportunity to say, we'll have you, no, we won't have you, and we're able to pick the cherries out of the barrel. It's actually better for the health system that if general practitioners are doing some of these things, because it does free up those specialists, so they're actually doing the really difficult cases rather than just the mundane advanced stuff. So the specialists aren't doing the easy stuff, and it creates less of a waiting time for your endo, your ortho at the dental hospital. It's also about clinical leadership, being an actual leader as a clinician. It's something I believe is actually doing the right thing. And like most things, the more you do something, the better you get at it. Because if you don't get better after doing it lots of times, there must be something wrong with you. Similarly, if you don't practice it, you actually de-skill yourself and get worse at it. How do we go about achieving this? Well, it's all about gradually extending yourself, going outside that comfort zone. You don't need academic excellence. I'm a living, breathing example of that. I failed third year. They keep the good ones back. I was known as Mr. 51%. I say, well, if you get a H1, you're going to charge more for your fillings. But it's all about common sense. And the thing is, it's about starting off small, starting off with the easy stuff and gradually extending, getting out of that comfort zone. Not jumping in at the deep end. Cowboys who do that sort of stuff always come unstuck. And it's a good idea if you are doing this to cultivate a friendly mentor or specialist. I remember when I first started at where I work now, the dental hospital, at Golden Valley Health. At the interview, they intimated to me that they expected me to do the fractured mandibles that come in. And I thought, ooh, I better find out how to do that. And I was at a conference the week before I started in Brisbane, and I was looking at a poster presentation of an oral surgeon, and he came up and he said, oh, you're interested in that? And I said, yeah, but I'm also really interested in how to do fractured mandibles. And he broke it down for me so simply and easily, because I said, there's a surgeon that's doing them, and he said, well, you should be doing them because you understand occlusion. And he said, you just make the top jaw as a splint for the bottom jaw and put them together. And I said, yeah, I could do that. And similarly with the local orthodontist, when I was trying to find out how to do lateral ceph tracing, I'd sent him hundreds of referrals for our patients. So I rang up and said, oh, look, just wonder if I could pop around. You can go with me through some lateral cephs on how to trace. And I found those things easy to do, and just having someone there to guide you really helps. Of course, attending courses, reading up on the subject, that's the sort of thing you've got to do. And these days, YouTube. There's all the new graduates that work with me, they tell me, oh, that's all on YouTube. You can learn how to take out wisdom teeth and fix holes in antrums and that sort of thing through YouTube. So those sort of resources are available. But it's important to emphasise that you are not a specialist. I say, well, look, if you want the best is seeing a specialist. We do that sort of work, but we are not specialists. Particularly on the orthodontic side of things. We basically just align level teeth and try and close the gaps up. And if they want the best, yes, we can refer you. The other thing is, don't be afraid of mistakes. Mistakes are how we learn, and they're very, very powerful learning tools. It's all about taking calculated risks, not jumping in at the deep end. With orthodontics, just a word of warning: don't let it take over your practice and where you work, because as soon as the public finds out you do this sort of work, you just tend to get swamped. And I spend a lot of my time saying, no, I'm sorry, we can't or won't do that. Particularly the ones with the slightly rotated lower central incisor. You just don't. No, we won't do that because it's just not a good use of public money. But if you are going to do orthodontics, start off with something small, something easy to do, something like slightly displaced canines, a full arch band up with a bit of interproximal stripping, and they come into line beautifully. And from there you can actually try, well, what's the next step? What else can I try? And you will make mistakes, but the thing is building from that and learning from that. And I do want to spend a bit of time on mistakes, because mistakes, part of development, part of learning is making those mistakes. And I do have a lot of students and graduates say to me, "Oh, but David, you're so experienced." But I say, well, look, experience is the name I give to the sum of all my mistakes. That's how I learned, because I made a whole lot of mistakes. Because if you don't extend yourself, if you don't sort of go outside that comfort zone, you'll be all you'll be doing is class 1 amalgams or class 1 composites for the rest of your life. You've got to try and extend yourself, because mistakes are a part of that extension experience, as long as you learn from that. And I think mistakes are a bit like a bad love. The more you learn from it, the more you wished it never happened. So we're not having questions, so I will say thank you.